Assalamu alaikum. I'm Dr. Ramisha Zahid Shah in September 2023. Today we will be talking about two lymphomas in this video. It's nodal marginal zone lymphoma and lymphoplasmacytic lymphoma. So, nodal marginal zone lymphoma, for a brief introduction, I would say it's a B-cell lymphoma, and it is derived from post-germinal center B cells. The marginal zone of the follicles is it arises from that area. It resembles the extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue, that is MALT, and also the splenic marginal zone lymphoma. It has same morphology in IHC, like extranodal and splenic marginal zone lymphomas. So let's give it a look. The morphology is of small cells, and it's a small cell lymphoma, like we have previously discussed other small cell lymphomas like CLL, SLL, and mantle cell lymphoma. This also belongs to the category of small cell lymphoma. The cytoplasm is abundant and it's pale. If it's circumferential, it gives these small cells a monocytoid appearance, and they look like monocytes, having a central nucleus with abundant cytoplasm. And if the cytoplasm is at the periphery, it gives more of a plasmacytoid look. Then there are scattered large B cells. The pattern of these cells can be nodular. They can involve the perifollicular area. They can be interspersed between the interfollicular area, or they can cause follicular coronization, a process that we know very well in mild lymphomas, or the cells can be diffuse. So let's look at the IHC. Like we said, it's a B-cell lymphoma. It is positive for B-cell markers like CD20, other B-cell markers like CD19. CD43 is also positive in it, and CD43 is actually a T-cell marker, but its expression in B-cell lymphomas is aberrant. This CD43 expression alone is not really helpful, just that it's telling us that it's a B-cell lymphoma. Its aberrant expression will just highlight that it's a B-cell lymphoma. So how do we diagnose nodal marginal zone B-cell lymphoma? Are there any characteristic IHC markers for that? Well, for that matter, for nodal marginal zone B-cell lymphoma, it is the negative markers that will help us in making a diagnosis. CD5 will be negative. That will rule out other two negative, that will rule out the other two small cell lymphomas, that is CLL, SLL, and mantle cell lymphoma. We can apply further markers like CD23 and LEF1, that and their negativity is going to confirm that it's not CLL/SLL. We can apply cyclin D1, and its negativity will confirm that it is not mantle cell lymphoma. And finally, we can apply CD10 and BCL6, which will be negative and that's how we are going to rule out the follicular lymphoma. And also we know that these are CD10 and BCL6 are markers of germinal center. And like we said, that it's a marginal zone lymphoma, so it's a post-germinal center lymphoma. So CD10 and BCL6 are going to be negative. So what are the other points that we need to know about nodal marginal zone lymphoma? Well, it's an indolent neoplasm. It's an indolent low-grade B-cell neoplasm. The prognosis is excellent. The patients have a very good survival. But the only thing that we need to remember when we see a case of nodal marginal zone B-cell lymphoma is that we rule out either it's an extranodal marginal zone lymphoma of MALT tissue, or whether it's a splenic marginal zone lymphoma. We must rule out the METs from these sites, as they are more common than isolated nodal marginal zone B-cell lymphoma. Another entity that is a provisional entity in WHO is pediatric nodal marginal zone lymphoma. It presents as head and neck lymphadenopathy. So the morphology is same, IHC is same. Immunophenotype is same, just that the patient is young and presents with head and neck lymphadenopathy. The prognosis is excellent, even with the conservative therapy. And the survival, as we see in the nodal marginal zone lymphoma, the survival is long-term and good survival. Next lymphoma that we will be discussing is another small cell lymphoma, which is lymphoplasmacytic lymphoma, an important differential of nodal marginal zone lymphoma. It's lymphoplasmacytic lymphoma, and it's seen in old age population. As we look into the morphology and we see its name, so there's a population of small lymphocytes, lympho, the plasmacytic component, that is the plasma cells and Dusher bodies, and what lies in between is a spectrum of plasmacytoid lymphocytes. And because of this, we can definitely have a differential of extranodal or nodal marginal zone lymphoma because of these small lymphocytes and plasmacytoid lymphocytes. Scattered are also seen plasma cells and Dusher bodies. When we go for the IHC, it presents a very similar picture. CD19 and 20, the B cell markers are positive. CD38 and 138 are positive in these plasmacytoid lymphocytes and plasma cells. And FMC7 is also positive. Again, we will look at the negative markers to rule out other small cell lymphomas, and it is also a diagnosis of exclusion. We have to exclude other lymphomas before we finally give this diagnosis. CD5, CD23 will be negative, ruling out CLL, and CD5 will also rule out mantle cell lymphoma. CD10 will rule out its origin from follicular center, germinal center, and CD103 and CD56 will be negative. CD103 will help us in ruling out hairy cell leukemia because lymphoplasmacytic lymphomas also involve spleen. So hairy cell leukemia is common there and is positive for FMC7 and CD103. So in lymphoplasmacytic lymphoma, FMC7 is positive, but CD103 is negative. CD56 is negative, so we are ruling out plasma cell neoplasms. The genetics for lymphoplasmacytic lymphoma mid-88 is very characteristic for it, and it's diagnostic. So if we are suspecting a plasma cell neoplasm, or if we are suspecting, or if we are having differential of nodal marginal zone lymphoma, and if we get the genetics done and it's mid-88, then it's very much diagnostic for lymphoplasmacytic lymphoma. So the points to remember are that it's an indolent neoplasm, but unfortunately, it's incurable. So the patient may die of disease progression, transformation to DLBCL, or some therapy-related complications. So it's an example of a tumor of a neoplasm that's indolent but incurable, that eventually leads to patient's death. Patient can have Waldenstrom macroglobulinemia, and the poor prognostic factors include age more than 65 years, low hemoglobin and platelet count, and any elevated monoclonal IgM or beta-2 microglobulin. So there's some recommended material. Hope you go through it. Thank you for listening. Allah Hafiz.